Our first speaker is Dr. Mark Blatt. He's the Director of Healthcare Industry Solutions at Intel. Dr. Blatt joined Intel in the summer of 2000 working in the New Business Group. He is currently Worldwide Medical Director, Enterprise Solutions Sales in the Sales and Marketing Group. In this role, he is concentrating on how HIT infrastructure can enable providers to deliver cost-effective, quality care to a wide cohort of citizens. He has a particular interest in integrated care delivery, mobile point of care, secure computing, and the emergence of cloud computing services. Dr. Blatt has worked with care delivery systems in many countries, including the UK, China, Mexico, Australia, and the USA, to enable cost-effective, sustainable systems that will allow clinicians to provide virtual care to patients in settings as diverse as rural, remote clinics, or the patient's home. Prior to joining Intel, he was a managing partner of a 5-provider group in family practice. He practiced family medicine for 15 years before returning to Yale University to earn his MBA in 2000 in finance. Dr. Blatt earned his medical doctorate at Albany Medical College of Union University in 1979. He completed a residency in family practice at the University of Connecticut in 1982. He then served 2 years as a commissioned officer in the U.S. Public Health Service before starting private practice. Dr. Blatt is a member of the IEEE Medical Technology Policy Committee, the American Telemedicine Association, ATA, HIMSS, a lifetime member of the American Academy of Family Physicians, and a diplomat of the American Board of Family Practice from 1982 to 2010. Dr. Blatt.
When you know she's no high climber, then you find your only friend in a room with your two.
Well, thank you very much for allowing me to come here and talk to you all. I really appreciate it. I hope to make the next 45 minutes a bit fun and a bit entertaining as well. Family doc, Intel. How did I get here? I'm going to tell you a story about how I decided to change careers. I took call on a holiday weekend, a 3-day weekend, and if any of you are clinicians out there, you'll know a call on a 3-day weekend can be bad. I was taking call for about 12 other primary care docs, so Saturday morning I knew was going to be busy. I get up in the morning, do rounds in a couple of different hospitals, get back to the office, put a headset on, and the answering service starts coming at me. Probably between about 8 a.m. and noon, I must have gotten several hundred phone calls, 200-300 phone calls. It was just crazy. It's Saturday morning. It's a holiday weekend. You can't send everybody to the walk-in center, the emergency room. Your colleagues are going to hate you. So I did what was reasonable. I started treating people rapidly on the phone. By the time I was done, I started thinking about this. On a Monday morning, all of these calls would be intercepted by various secretaries. They become billable events in the various offices. Patients would take a half a day off from work, pay us $100, and they'd pretty much get the same outcome. I saw them for free in 30 seconds on the phone. Only problem, of course, it was free and it might not have been quite legal. But other than that, it was a great idea. So I started to think, what am I doing in my office? I felt a little bit like a shaman. And that's when I started to say, there's got to be a way to deliver quality health care for literally 10 cents on the dollar or less. And that's why I started to change careers, and that's when I headed back to Yale. So that's what I kind of want to share with you, this hallucination that there's a way to deliver care differently, dramatically differently. I'm going to talk to you a little bit about some of the trends that came out of high tech and era. Not going to spend a lot of time here, but I want to emphasize 3 trends. Then I'm going to talk to you a little bit about how I think technology can help deal with these changes we're dealing with. We'll talk about the cloud and what the cloud means. We'll talk about coordinated care, collaborative care models, which I think is a fundamental change in how we deliver care. Doing great care within your own sandbox, within your hospital, your clinic, your office, following evidence-based medicine, using tools, that's exactly what I expect of you, but that's only a start. Coordinating care, coordinating the supply chain from the beginning to the end, across the care continuum, whether or not you think that's your job, unfortunately, that's about to become your job. We'll talk about ways that can make a difference, ways that can matter. I'll show you some evidence there. and then we'll kind of dive a little bit into mobile computing, which I think is critical for being able to coordinate care. Okay, so if I look at the trends, this is the biggest trend. Healthcare is unaffordable. Okay, I think we all kind of know that instinctively. As a product, we've raised prices about 6% every year since World War II. Arguably, we bankrupted GM. Now, it might not have made sense to give $1 healthcare coverage to every employee and retiree following World War II, but they did. I don't think they expected medical inflation to outpace the CPI. We've produced a product that you deliver, which is unaffordable. No one can afford your service. I don't care how wealthy any of you are, you can't afford the product. If you were to lose insurance, you could not afford to get health care in the US. The government can't afford it, companies can't afford it, and citizens can't. So something has to give. We're essentially the 2006 housing market. If I would have told you in 2006 that your housing price over the next 5 years would fall by 50%, you would have told me I'm crazy. You had 60 years of history to tell me I'm crazy. It's gone nowhere but up. I'm going to tell you, I don't think bending the curve is going to work. I think what you're looking at is a decade of deflation. You're basically looking at healthcare costs going down in every area. So when high-tech passed and they decided to give you 30, 40 billion as incentives to deploy IT systems, within the same bill, this was the AMA's estimate of the price cuts, $500 billion worth of price cuts. So like any rational businessman, the president wants a 10x return on his investment. I'm going to give you 40 billion, I want 500 back. That's the equation. So spend your 40 billion quickly and spend it wisely. The payments are cut across home care, inpatient, outpatient, physician savings. This was what was on the books. Whether Congress does it, well, Price Waterhouse estimated this was the waste in the healthcare system. So that's the good news. I don't actually have to cut your salary in half to do this. I can actually look at how to remove waste from the system and actually deploy IT to do that. The second thing that's in here are the breach notification laws, the security laws. They got a lot stricter. Now, we all know about HIPAA. HIPAA started up in '96, kind of became serious about it '06. Anybody know anybody who ever got sued or had a problem under HIPAA? I don't. Actually, there was one organization on the West Coast that the Inspector General went after. The difference under high-tech is the standing and who has the right to prosecute changes. The state attorney generals now have the right to prosecute under high-tech. And actually, they've devoted money to teaching the state AGs how to enforce the law and go after you for fines. Now, I'm from California, originally from New York. Both of those states are bankrupt. I'm not sure about Jersey, but if I'm the state AG, I'm looking for fines and I'm looking for where I can get money. So having exposed PHI and having it get lost starts with a trivial fine at about $100 and rapidly escalates to $1.5 million. And it applies to the individual organization or doctor. That's a shrunken copy of the breach list where you actually have to publish your breach. You have to do it within 60 days or now it becomes a criminal penalty, not civil. And I'll show you a little bit more about the breach list as we go forward. So breach notifications are an issue. The last one, and you probably know about this, are readmissions to hospital systems. We don't, as an organization, healthcare, do a great job when it comes to hospital readmissions. A big study published just about the time the high-tech law was going to come out basically showed that readmissions to hospital systems tend to run in 30 days around 20% for all Medicare patients, Medicare. 20%. How many of you would buy a product that had a 30-day, 20% defect rate? That's one way to look at it. You might also say, hey, you know what? That's not my problem. I send the patient out. They're doing great. They're tuned up. They don't listen. They don't comply. They don't take their drugs. Congress is about to say it is your problem. They're going to make it the hospital's problem to manage people. And about 2 weeks ago, CMS, or CMMI, part of the Reform Act, came out with 4 different bundles, which you should become familiar with, which are another way to start paying you going forward. Bundling acute care, post-acute care episodes. For the first time, they actually looked at bundling just post-acute care, essentially an outpatient DRG. And that's going to be kind of interesting. I'm not sure I want to be on the board and figure out who gets what money, but Bundling care is actually going to be the way to do this, and decreasing readmissions. And it's actually very doable. So the penalties that start to kick in for hospitals start to kick in, or the reporting requirement starts to kick in about 10 days. So if you haven't started planning for this, you're already behind the curve. So starting October 1, fiscal year 012, hospitals have to start reporting the statistics for discharges among the common DRGs. And again, they're common DRGs, heart attack, failure, pneumonia, and in 014 it expands. You add up those 7 DRGs, if I'm a hospital dude, that's probably about 80% of most of my admissions in my DRGs. I bet the rest, the bulk, are live births. So this is really covering most of the med surge that goes on in your hospital systems, and how you're actually going to discharge people and how you're going to care for them. And they're saying you got to keep them out of the hospital. If you don't, what happens is they take away 1% of your total Medicare fiscal payment, and then 2, and then 3. So for this one reg alone, about 3% of your fees are at risk. Does your hospital have greater than a 3% margin? If it doesn't, they're not quite bankrupting you, but they're taking away all your profits. So figuring out how to keep people home is going to be a task. Well, if I actually do want to manage cost, if I actually do want to go forward and control cost, if I believe the premise that healthcare is too expensive, it's the 80-20 rule. Most of the cost involves chronic disease. We're not talking acute trauma, we're talking chronic disease and chronic illness. And how I control chronic disease and chronic illness is going to be critical to how I lower cost, dramatically. And I'll challenge you with the real trick here, is tell me over the next decade how you're going to lower costs literally by an order of magnitude. Not take 10% or 5% off, but how are you going to take a 0 off the equation? Go back to my Saturday morning. I treated 80% of the patients in 30 seconds over the phone for free. That's a sea change in how I deliver health care. Now, admittedly, I didn't get paid, but that's a sea change in how you do it. It's doable. So how am I going to control chronic disease? This is ultimately the problem. If any of us have elder parents, or we've been sick with a chronic illness in the hospital, we all know the ologists don't talk to each other. The cardiologist doesn't talk to the neurosurgeon, who doesn't talk to the, and on and on. We know we're repeating the story over and over again. And the elderly, again, the 80-20 rule, it's 80% of the admissions, 80% of the visits, 80% of the scripts, and they see, what, 50 different prescriptions in 13 different docs? That's a huge coordination problem. And again, if I take it back to manufacturing, which Intel knows something about, it's really a supply chain management issue. How do I get the people in the supply chain collaborating on my behalf, the customer? So that's the analogy. So care coordination makes a huge difference. Caring for people in different venues makes a difference. This, again, was testimony in front of Congress from a crazy bunch of people called the Primary Care Collaborative. And in the Primary Care Collaborative, data exists that shows that home care might be the best venue for caring for people, not your office and not your hospital. Home care. These are the sickest patients, because these were homebound patients that I had a CPT code that I could bill for. That meant they were non-ambulatory, they couldn't come to my office. So in inner city, New York City, Penn, Virginia, all across the area, they decreased hospital admissions by over half by making home visits. Crazy group of doctors, American Association of Home Care Providers, they don't have offices. All they do is home visits, about 6,000 docs. And look at the consequence. They drove down costs by about 25 to 50%. But they cut hospital admissions by 50. How many of your hospital systems are ready for this? How many are ready for the changes where half of your bed days of care go away? And that's essentially what's coming. America, over and over again, looked at templates of what was going on in other countries. I'm a worldwide medical director at Intel, so I get the privilege of traveling quite a bit. Sweden is probably the best example. Admittedly, it's a country of about 8 million people, fairly homogeneous population. 10 years ago, they had 175 hospitals. Now they got 75, and they have plans on the book to go to 35. They're devolving care, improving communications, and caring for people in ambulatory environments. Hospitals are not the best or most efficient way to care for people. So if you look at the CARE Act, it's got a couple of things in common. It's how do I care for people in the lowest cost setting possible? How do I drive cost out of the system? How do I prevent readmissions? Yes, specifically. But ultimately, how do I prevent admissions? How do I stop unnecessary trips to the ED? How do I decrease office visits? My Saturday morning. Wow, that starts to change the nature of what I do. And that's the ultimate message, I think, for clinicians. The job you do, the job you were trained for, is going to change. And these are just some dramatic examples of how that job can change. Just doing home care? What you thought you signed up for when you went to medical school, nursing school, or trained is ultimately going to be different. If any of you are primarily in IT, and you're as old as I am, the job you're doing in IT resembles nothing about the job you were trained for. Even the work you were doing 10 years ago is dramatically different. Yet healthcare, we're moderately proud of the fact we haven't changed in a couple hundred years. Not the diagnostics, not the therapeutics, but the process is unchanged. And it's the process we're talking about here. It's the process that's driving up cost. The VA was faced with an interesting problem. The VA started to deploy IT in the United States dramatically, and this blows me away because if any of us are my age and trained, we all trained in the VASPA, and we knew how it was kind of a great place to train because nobody was there and you could do anything you wanted. But the VA has transformed itself as an institution. Starting in the mid-90s, they started to adopt IT. Starting in early 2000, they realized they were going to face a really big problem. The number of vets looked like it was going to about to double over the next decade. We went to go fight a couple of different wars in places, but their budget was going to be flat to slightly down. Now that starts to resemble the cost cutting in the curve I was talking about. Twice the volume of patients with no increase in budget. What are you going to do? They decided to turn to technology. They built an electronic medical record system for 127 hospitals, thousands of clinics, every lab value. They brought it all together. And then they started to coordinate care. They started to enroll people in care coordination programs with remote monitoring. And the first outcome was, again, a 20% reduction in admissions, 25% reduction in bed days. Again, we're starting to approach the numbers that are really meaningful. It changes the way you organize a hospital. 25% reduction in bed days. High acceptance of the technology. And here was the bottom line. The cost of primary care for admission, a trip to a nursing home, for their sickest patients was over $70K. And once they started to do this, they took out 80% of the cost. They dropped it to $13,000. Starts to look like Saturday morning. But then they went another step. They said, you know, this is too people intensive, this care coordination. We can't do it. So we're going to basically automate the process and do remote monitoring, put scales in homes with CHFs, spirometers, and we're going to start to monitor our patients in the outpatient environment. And they took out another 80% of the cost. So look what they did at the end of the day. They took out 98% of the cost for caring for their sickest patients. But the job the doctors were doing was completely different. They wouldn't have a packed clinic. They were reviewing charts and monitors of people with their home monitoring systems. It's not what I signed up for when I went to medical school. But the cost savings are compelling. And it wasn't a small N. Look at the numbers here. Thousands, tens of thousands. And it wasn't just one condition, heart failure, those are some of the things that accessory admissions are all about. There are also some of the targeted healthcare plans for the ACOs. But again, diabetes, post-traumatic stress, depression, psych as well as med, and utilization decreases again, now approaching 50%. So Congress looked at this and said, we want you to all be like the VA. We want you to all be like Kaiser. We want you to all coordinate care. When I talked in front of the American Academy of Family Docs about a year ago, I said I became a family doc because I fell in love with Marcus Welby. I wanted to do the home visits, the whole 9 yards, take care of people. Again, I keep telling you the job is about to change. Marcus Welby's dead. It's a nice television show, but I can't afford to deliver care that way. No one can afford to pay for care that way. So the trend summary kind of goes, costs are going out of control, hospital admissions and readmissions need to be reduced, data breaches are going to nail you, and you got to treat patients in the lowest cost setting possible. So how can I do that? Well, the first thing to think about is the cloud. Now, a lot of us think about the cloud as some crazy technology, but I'm going to offer you a different thought. The cloud is a business decision. It's not a technology. It's a business decision. So if you're a CIO and you sit on the executive board, this is a business decision about how you're going to consume and utilize computing power. Now, you're going to build a brand new hospital. So the first thing you're going to go do, obviously, is put up a hydroelectric plant so you have electricity, right? Maybe not. Maybe you hook to the grid. But you got to have a phone system, right? So you're going to go create your own phone company. Maybe not. Maybe you hook to a phone company. But you got to have a IT, so you're going to go build a data center. Maybe not. That's the cloud. Maybe you don't need IT, a data center. Maybe you don't need it all behind your firewall. Maybe you hook to a computing grid, and you absorb computing power just the same way you pay for electricity. You don't turn on, you don't go to the electric company and say, I want 5,000 electric seats, and I promise. That's not how you do it. You turn it on, you turn it off. And that's really what the computing power is all about. It's software on demand, service on demand. A lot of you will probably, if you start out here, it's going to be with software or probably network. You're going to start to buy infrastructure and network storage, and that's probably one of the simplest, easiest ways to go. And then you have to decide, do I put all this behind my firewall and make it a private cloud? Do I absorb public cloud services? Do I do something like outsource all my billing to Salesforce? Okay? Or do I do some kind of model in between? I'd suggest to you a model in between is likely the best way to get started. It's a business decision. It's how you're going to consume services, how you're going to consume computing power. The cloud has a tremendous bunch of efficiency in it. It's expandable. You can grow IT projects very quickly without a lot of capital expenditures. It becomes an operating cost. It's efficient, it's agile, it's available. Man, it sounds like nirvana. Not quite nirvana. The problem with the cloud is every cloud has been hacked in the last 6 months. I can't think of a cloud that hasn't. It's kind of almost comical that RSA, the security organization, gets hacked. World Bank gets hacked. I think World Bank probably has better security than most of us. My Sony PlayStation got hacked, for God's sakes, and I couldn't play games. I mean, businesses are going down and facing serious problems. And remember, I told you, breaches are going to be costly. Whether or not they're your fault, it's not going to matter. Breaches are going to be costly. So the cloud has some issues. I think it's the way you have to start to think about. It's a business decision, and you have to start to think about how you're going to mitigate risk and move there now. But I'm not sure I'd jump in with both feet and just say nirvana. There are security risks. There are audit risks under HIPAA. How do you actually comply with data up in the cloud? New Jersey doesn't have data localization laws, but the other states in the continent do. Texas is particularly crazy. They won't let the data be stored in Jersey. It's got to be stored in Texas. So Amazon, Google actually build data centers in these places. They build them in different countries because of sovereignty laws. So I don't want my VMs falling over and going to virtual machines in different locations. I need to know where my data is and I can audit it. And that may not be that easy in the cloud because that takes away the scalability, availability, and efficiency. And then vendor lock-in becomes an issue. How do you get your data out of the cloud if you want to switch? So there's just going to be constant tension between all the wonderful provisioning, availability, lower cost, OpEx, and the regulatory risks. And you're going to go back and forth. And whatever I say today isn't going to be true in a year. And I don't know how this will work out, but I still think you have to get started. You have to start moving towards the cloud. And this is the way Intel decides to do it. This is the way Intel actually decides to put things together. I look at my non-mission critical applications and I say, those are the things I'm going to put up in the cloud and I'm going to consume as a public service from someone else. From Intel, it's my expense reports. IBM does it. It's my training environment. Siemens does it. We go to different public cloud providers and they offer us services that if they went down, I can recover from. It's not mission critical. What's the equivalent in the hospital? What about a scheduling service? What about training for onboarding for nurses? Those are the types of things that you might want to start to outsource to the cloud. I'm not sure I want to put my EMR up in the cloud. I know there are EMRs that are available, even free ones in the cloud. And free is a good price point. But again, I'm not sure I want to go there just yet. It's going to get better, going to get more available, and going to get more secure. But a balanced computing model where you take advantage of what's going on in the cloud, balancing it with your network requirements, and actually local data execution on the client, that's probably the best model in the near term for the next 3 to 5 years, as you set yourself up to move more and more services into secure clouds. So all of a sudden, you've got to make multiple decisions. What's my compute model? Is it hybrid cloud? Is it public cloud, private cloud? And these become a set of business decisions which drive your technology. Now, what are you going to do with all this stuff? Okay, so let's go back to that theme of integrated care delivery and care coordination. I need to lower cost. I need to drive massive cost out of the system. So I got to get those ologists talking. I've got to get integrated care for the 80% of people that are driving my costs, the chronic disease. That's what I'm concentrating on. So what does this take? Well, the first thing it takes is a team approach. I'm not sure about you all, but I never really worked as a team much as a doctor. I either led something or I wasn't there. But coordinating care is not what I thought of as my job. I wrote a consult, I wrote a note, and somebody else read it and did something. But now I'm responsible for being the band leader. I need comprehensive information. I need data sharing. I need data exchanges. I know New Jersey's building a data exchange. The states around you are building data exchanges. How do I exchange data? Is it, again, in a public cloud, a private cloud? Is it a hospital offering? Is it an ISV offering? But I know exchanging data and having data available everywhere is important. So I kind of summarize it into 4 activities. Meaningful use part 1, gather data. Build med lists. Do e-prescribing. Gather and digitize all the data in your system. No smoking status. So gathering data is step 1. Sharing data is step 2. Mobilizing data and making sure that you give it to providers on whatever platform they want is critical. Mobile care, mobile data. Is it on a handheld? Is it on what type of mobile platform? It doesn't matter. I need to get the data to them. And that, again, complicates your job because you got to do it securely. And if you're coming out of the cloud, it just adds more complexity. And finally, I need to give the data to citizens. I need to take the data and empower them for care. And again, if I'm going to be an ACO, care plans and patient empowerment are critical. So gather, share, mobilize, and empower citizens. Those are your tasks. And I think you start with gather. If you do any one of these 4 tasks, even if you just do the exchange, even if you just go mobile, I guarantee you'll shave 10, 20% off your costs. But if you want to get to that transformational effect, that 90% change, deal with a 50% fee cut that might be coming, then unfortunately you got to do all 4. And as you do all 4, what you end up doing is creating a virtuous web of data. It's data everywhere. So the more data you mobilize, the more data you have to gather, the more data you have to share, the more data you have to bring back to the citizen. And you create this circle of moving data. Now you have to audit it. It has to be secure. You have to know on what device it is. You have to be able to wipe. You have to do a whole bunch of things to build your security environment and your privacy regs. This becomes a whole lot harder than client-server to terminals behind the firewall on Wi-Fi or wired connections in your hospital. It's orders of magnitude more difficult. But it's the only way we drive cost out of the system, is to build these care coordination tools. And think of them as tools. You're building tools to allow the clinicians to work in better environments, not just the doctors. And this is where we're concentrated right now. Hospitals, academic centers, PACS systems. Oh, we got a regional PACS. All great starts. You will drive costs down 5, 10, 20%, I guarantee it. But if you want the order of magnitude change, how do I hook into CMS? Remember, one of my tasks is to avoid unnecessary transports to the ED. Who better than CMS to do it? But that's a change in how CMS works and thinks. Ambulance drivers go out and transport people to the ED. Could I treat a kid's asthma attack in-house, in place? $1,200 versus $7,000 if I transport them. It's a change in policy. It's a change in the way I organize care. How do I get home care involved? How do I get the pharmacist involved? How do I get I don't work with community nurses and community. I sometimes sign a bunch of orders they send me. I don't look at them. I just sign them. So actually integrating care with multiple venues and multiple settings with multiple actors, and sometimes people beyond your firewall and on your control, is critical. And you got to do it securely without a HIPAA violation or without a high-tech violation? Becomes hard. So let me suggest to you a hallucination, admittedly it's mine, for care coordination. This is a workflow storyboard I put together in the lab at Intel that depicts what might happen when a patient comes into the hospital and gets a consult. So kind of up here, right tool for the right job, especially if I'm going mobile. If I'm a doctor and I come into the hospital and I want to look up my schedule, best thing to do it is on a handheld. Smartphone of some sort is going to be your easiest way to locate your patients, know what your schedule is, know where you want to go. But now I want to educate a patient. Maybe the best way to educate a patient, come up to them with the PACS, the archive, show them something on a tablet. It's quick, it's easy. But it's hard to run multiple videos on a tablet, and the strain on your VM architecture, if you're running it through Citrix or VMware, is quite astronomical, even for running one video through VM. Because you're running it on the server, and you're using the client as a terminal. Hey, it's highly secure, it's highly available, and it works within your firewall. It gets a little expensive when you do it on a wide area network with cellular. You're paying for bandwidth now. But highly secure, highly manageable. Probably not a bad way to deliver education. Now all of a sudden the guy gets admitted, a stat break in a bone, I want to get a cardiology consult because his EKG is abnormal. So now all of a sudden Dr. Bones and Dr. Hart want to talk to each other. Okay, you might come up with a different example, but the idea is how do I move people through the system quicker, and how do I get stat consults when people are stopped waiting for something to happen in the hospital? Stat consult, if you're really an amazing hospital, might be done within hours. Could take a day. What if I told you the SLA for this should be 15 minutes, and most of the time done in 5? That's an order of magnitude compression. And that changes, again, the way we work and how we do things. I don't write a consult in the chart, throw it over the wall, and hopes it gets done. I might initiate a video call between the two different doctors. I might start looking at the telemetry. The video call's got nothing to do with the EMR. The telemetry's coming off Welch, Allen, Siemens, Draeger, something outside your EMR. Maybe you're importing it through a portal. And now I actually start to make a decision because I'm seeing the PACS of telemetry. Maybe the two doctors get a third one involved, and this one I thought the PharmD might help them. Oh my goodness. And that was one hallucination about care coordination. Here's another one, a time of discharge. And again, this was a storyboard, and we built technology to support it. Surgery gets done, the discharge orders get written, the discharge plan gets done, and now a nurse is left to communicate the discharge plan to the patient. How many of you have ever been there at discharge day with a parent? All of a sudden, all the meds are new. They change from one therapeutic class or therapeutic substitution, maybe a bunch of generic meds. Things got changed. Things are different. It's not a peaceful day. It's a very hectic day, discharge. Often, you know, your mom's there, maybe dad's there taking her home. You go over that night and you say, what'd the doctor say? What's the answer? I don't know. So a different doctor every day. I'm not sure. When are you seeing him again? I don't know. We'll call our family doctor. No wonder we get 20% readmissions in 30 days. It's maybe a wonder it's not even higher. So what if standard kit was, at the time of discharge, the nurse on the ward with the discharge summary, which was dictated in real time with the med list, contacts with a video call, Skype, whatever, the nurse where he or she is going, the community clinic, the doctor's office, the rehab center, the SNF, I don't care. But they do a sign out, they do a handoff, the same way they do at end of shift. Nurses at the end of shift don't walk into the call room with 30 pieces of paper, throw it at the next nurse and say goodbye, good luck, take care. They sign out. In 20 minutes, they communicate 30 patients. They're really efficient. They can do this in sub 1 minute. Okay, so now it's standard kit that the two nurses communicate. I guarantee if you just get a discharge summary over there, even in real time, there'll still be a question about it. There'll still be an issue. Why this med, why? Now they, bing, 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 they explain it. Then as the third video conference, they bring up the son, the patient's family member, the caregiver. He may not be there, maybe at work, maybe 1,000 miles away, living in another state, and I want to care for my mom, my dad. So now we have a three-way video conference, and I'm looking at data, and I'm looking at video. How do I put that envelope together? So this is what a screen might look like. We actually built this, and we're going to start to demo this. So this has got a little bit to do with the EMR and meaningful use, but it's got a lot to do with collaboration and how I build collaborative tools coming out of a cloud. So here's these two rather unsavory characters are pretending to be doctors. They're technicians up in Intel, and the cardiologist and talking, and I'm launching a three-way video conference. I'm building up a real PACS archive, and I'm doing a telemetry. 5 video windows opened, and I'm doing a med list that I'm viewing out of an EMR. And while you can't exactly see it here, server utilization is 1%. How did I get server utilization to 1% with 5 video windows? I'm in a Citrix environment, but I'm using a technology called multimedia redirect. I'm executing a video stream, not a VDI envelope from the server, but a video stream on the client. I'm actually running the information on the client. Anybody use Netflix? Yeah, come on, I know you do. We all do. It's great. Put my cable car out of business. $8, how do they deliver you streaming video? The point is, it is streaming. They're not executing the video back in a huge data center. Now, Intel loves the huge data center because that's how we're making most of our money these days. Building huge data centers because you guys are all doing VDI from Citrix and VM, and you're building, even with serverless virtualization and 10 or 15 to 1 compression, you're still running out of floor because of the demand on VDI. It turns out it's one of the most expensive ways to deliver computing power. Highly secure, highly available, it all runs on the server, I won't get a breach. But completely inefficient, and remember, you're broken, you're out of money. So doing multimedia redirect to the client, which is what Netflix does. And does Netflix care about the client? Not really. How many watch Netflix on their iPad, their iPhone, your Xbox, your TV, your Blu-ray player? That's the whole point. Different operating systems, different clients, different devices I brought to work, quote unquote. It doesn't matter because I'm streaming out of the cloud. So client-aware applications that stream out of the cloud is where you want to head. And the EMR is one data element that you have to worry about. Collaboration requires bringing a lot of different data elements from disparate sources together. So now these guys are together, and do you think that the orthopedic surgeon can get an answer to his cardiology question in 5 minutes? I think he can. I think this compresses a consult. And again, I'm not saying this is the only care coordination model. Maybe the nurses are another one. Here's a bunch of them. EMS in the home, discharge to home, treating people in place, getting someone admitted from the ED. After you already decide to admit them and you tell them you're admitted, how long do they lay in the ED waiting for a bed? Is it 5 minutes or 2 hours? If it's 2 hours, now your cycle time is too high, and you're piling up people in the ED, and your answer is, we need more ED beds, we need more capacity, we need a new tower. Maybe not. Maybe you just need to figure out how to get people out of the ED in 5 minutes. It's doable. But maybe it's real-time communications, real-time collaboration between the floor nurse, the ED nurse, and transportation, using tools that you already have available. You don't have to buy anything new. You just have to use the tools you have. So maybe a challenge, an AR, a call to action, is what would be the collaborative workflows in your environment that would change things? Is it around admission, discharge, coordination, workflow? All of you are going to have a unique answer. I gave 2 examples. Wasn't meant to be the be-all and end-all, just to be examples to get you thinking. How do I use IT to coordinate care? How do I do virtualization? How do I come out of the cloud? And how do I actually use the right compute model? Oh my God, this just gets more complicated. Hybrid cloud, public cloud, private cloud, the right compute model. Yeah, well, now I'm giving you 5 different compute models up here. And depending where I execute, where I work, I can go work online or offline. You want to work offline with PHI on a client? Are you crazy? Well, I'll show you how you can protect it and how you can add flexibility. And you can still manage it all centrally, and you can still isolate things in virtual containers on a client device, doing application virtualization, and sync with the server. It's much more efficient than these older computer models. And if you've actually bought Core i5 devices, if you've actually got Xeon or Core 5, you actually have this capability. You just may not have chosen to turn it on or use it. You don't have to change a lot of what you're doing, but the compute model matters. If you want to do collaboration and you want to just do virtualization, quote from Ballmer, this is what's going to happen in your data center. Again, Intel and Cisco love you. We're making tons of money on you doing this, but it may not be the most efficient way. If you actually start to send complex video over the network through virtualization, okay, it's going to put a strain on your network. Some of the technologies actually help at this point. Intel did a nice study here, and the only part of the study I want you to concentrate on is here. Using older servers, 5400 models basically, we did virtualization, VDI, and we found that we could probably put about 50 people up on a VM, use about half of the server processor, and, okay, 45, 50 people. Okay, that's what we could do. If we actually changed the operating system and we streamed both the application and the operating system on more modern servers, that's where I got to that 1% in my demo. But also, look what I could support in terms of clients now, mobile clients. 10x. This was the transformational change I was asking you to think about. How do I go from supporting 50 VMs to supporting 350 and still not straining my server? Admittedly, your network traffic doubles. That is a bit of an issue. But now it's a balanced compute model. I'm not just executing only on the server and using dumb clients to go mobile. I'm executing in a balanced compute model using streaming, virtualization, redirect, a bunch of different technologies which are now available and are only going to get better. This is why Netflix is succeeding. 25% of all US internet traffic is Netflix. 25%. This model works, and it's cheap. Anybody doing it? Well, Providence Healthcare. Providence is a unique system. It's got hospitals in Alaska, and it's got hospitals in Southern California. They wanted what you want. They wanted central control. They wanted security. They wanted everything integrated in one environment. So how'd they do it? Well, they went through the same thing we talked about. They used the different sets of applications. Some of the names have changed. They tried Blade, VDI, terminal services. And what they decided was streaming applications out of the cloud for anything that's an image, but virtualization for anything that's text. And that's what I showed you in the demo. I streamed those 5 videos, and I did VDI for the text. I don't care about the text. It's kilobytes. So now mixed compute environments, and I stitch them together with the last piece of technology called reverse seamless. Citrix, VM, both have reverse seamless products. It looks the same to you. I don't care if it's executing on the server or the client. So a whole bunch of technologies which now give you tools to allow your doctors, your nurses, inpatient, outpatient, beyond your firewall to collaborate. Intel's vision, secure hybrid clouds, federated, automated, client-aware. All sorts of devices hooked up to it. I don't care. A whole bunch of blueprints we have available, a whole bunch of ways of doing it. We'd be glad to share all of this for free. There's a bunch of websites, bunches of video casts, and a bunch of white papers at the end of this paper. I'm going to end by talking about mobile, specifically about mobile communications and mobile technologies. When you start to use mobile technology, you get an order of magnitude, well, you get a dramatic improvement in efficiencies, certainly 30 to 50%. Data is available at the point of care. I've been using handheld devices for 10 years since I've been at Intel, 11 years. It seems like doctors have woken up to handheld devices and iPhones and iPads in the last 18 months. And it's transformational. But the only thing you're actually doing with these devices is looking up data. Woohoo, I'm glad. I'm glad you're looking up data in real time. Other people have been doing it for a decade. But now, how are you going to use these tools to actually build collaborative workflows? That's the key. You need to go to the next step. Looking up data is critical. It'll save somewhere between 30 and 90 minutes a day. That's tremendous. That's a great start. How are you going to save 4 hours? How are you going to cut the day in half? How are you going to double your patient load and not raise your cost? That's my challenge. So now you need to collaborate. Some of the best places, again, for collaboration are where you're highly mobile. Okay? This is where we're starting, in the center of the food chain, doing CPOE, closed order entry, using mobile tools, doctors entering orders, nurses with cows and wows delivering meds. But what about, again, the EMS? I challenge you. How could EMS and the hospital integrate care services? And how could I improve time at discharge using mobile tools? Again, this is just kind of a Consumer Report suggestion about the right device for the right task. I showed you that in the storyboard. Look up data, kilobytes on a handheld. Maybe do education with one video stream on a tablet. But if you want to do collaborative care, you might need a more robust device, and you might need a different compute model. Again, different ways to think about devices, different tasks, different devices. Unfortunately, you're not going to get away with one client. How many of you carry more than one client already? I do. Well, most of us. Got a smartphone, right? Got an iPad? Yeah? Got a PC? You're up to 3. Anybody got a Kindle? Up to 4. Maybe a Mac? On and on. You're not going to be able to get away with one tool. It's not going to be a Swiss Army knife. You're going to use different tools for different jobs. And these might be some of the considerations when you look at the benefits and features you're trying to deliver. These might be the specs that you're looking at. Do I want software that's available offline? Do I want to compute? Now, if you're in the hospital, 5 nines on your Wi-Fi network, I get it. You can do that. But what about wide area network if I go beyond the hospital in collaboration? Now I want to collaborate with community care nurses, home care nurses, remote monitoring, EMS in the field, the pharmacist. Cellular? Any of you ever do a cell call that doesn't drop? Again, I'm not saying this doesn't change. A year from now, I have a different talk. I'm just talking about where we are now. So the wireless needs, the ruggedization, the multitasking, online. Why in God's name would you ever put PHI on a mobile client? You're crazy. I just told you the breach laws will kill you. And mobile devices are stolen. 2 million laptops a year. Intel loses 2 a week. And we're pretty good, but we lose 2 a week around the world. So I guarantee if you put PHI on a mobile device, basically assume it's going to go missing sometime. Either that or don't do it. So how do you still maintain security knowing the device is going to go missing? Missing is a bad thing. The costs just escalating, and it's the reputational costs that are the highest. So putting PHI on a mobile device offers you flexibility, offers you collaborative care, offers you a way to integrate care, but it's risky. You end up on the breach list. Anybody ever go to the public breach list? It's a public site available. There are about 500 people up there. I froze it because I went to Yale, so I thought it was kind of cute that Yale lost a laptop. But here, a guy in Texas, his office gets burglarized. He loses a desktop computer and is on the breach list. A private dock, $1.5 million, because your office got robbed. Give me a break. Things happen. So how are you going to guarantee security? Well, the first one is end-to-end encryption. That's probably the best safe harbor you have. Encrypt everything. Any of you run encryption tools on your devices now? Several, 20%. Probably more of you do. It slows things up, makes people crazy. They want to turn it off. Encryption often slows things up. Using solid-state drives and using the core processors that you already have available that you might have purchased and turning on AES-NI, it's a set of encryption instruction sets that already exist in the processor that works with the software to be more efficient, sometimes 3x more efficient. You can get boot times that go from 2 minutes down to 30 seconds or 20 seconds. That makes a difference. Not instant on, not your iPad, unencrypted, but instant on, we'll get there. Give us about 3 years, 2 years, we'll be at netbooks, ultrabooks. But if you actually take advantage of this, it's an encryption end-to-end from the server to the client at the file level, at the disk level. State Attorney General Blumenthal in Connecticut, 2 weeks after high-tech went into effect last year, sued a California company, HealthNet, because of a lost laptop in California that contained Connecticut Health citizens' names. They won. $1.5 million fine. By the way, how did Richard get so smart? 2 weeks after the fact. David's his brother. David Blumenthal's his brother, so I guess they talked. David Blumenthal's ONC. So encryption's a safe harbor. Intel actually offers you a lot of technologies that you probably already purchased. This is just a list of them. I won't go through them, but I just want you to know they're there, and you could pick up literature at our booth. And again, you could purchase this from multiple vendors, from Dell, Hitachi, IBM, Toshiba, Motion. Hundreds of vendors make this available to you. It's inside the chipset. The last one I'm going to leave you with is anti-theft technology. So anti-theft technology, to me, is a little bit like LoJack on the computer. And indeed, you'll start to see commercials talking about LoJack on the computer for Christmas. So here, if the computer goes missing, if the device goes missing, you can track it and wipe a file. But you could build a private container, and you could wipe just your data. You could leave the personal data alone, and you could just deal with your container. The compute model matters. Say that 3 times fast. Okay, so data protection. So you see your car get stolen, your office gets burglarized, you call up Computrace running Absolute software, okay? And you tell them my device has been stolen. They put out a poison pill into the ether, and the poison pill, when the computer wakes up by policy every 30, 60 minutes, an hour, two, whatever you set it, it sees the poison pill. It interrogates the files, sees if they're still encrypted, if they've been breached, and then wipes them selectively and creates an audit trail. You satisfied HIPAA, you satisfied high-tech. Your computer was stolen with PHI on it, and you don't have to declare a breach. And you had the flexibility to work online and offline. The computer will work even if there's not a wide area network possible. It'll wake up, it won't find a network, it'll brick itself, it'll freeze the hardware. So there's a lot of ways to do it. And finally, the last crazy things it'll do, it'll actually turn on the GPS, it'll turn on the camera and the microphone if you wanted to. So you can locate the computer, you can take a picture of the thief and record the conversation. So if you steal a PC with the anti-theft sticker on it, that little sticker, first thing you should do is throw it away. Because when it wakes up, it's going to turn into a giant bug, and it's going to follow you. Absolute is reporting a 75% recovery rate of stolen assets. I just told you 2 million pieces. Before LoJack, were you ever going to get your car back before it was stripped? No. Now, don't steal a car with LoJack in it. Same idea. Intel built a tool to talk about your risks under high-tech for theft, anti-theft, working with others. It's available on our IPIP website, which you guys might go to. But you can actually kind of calculate the cost versus benefit of turning on anti-theft. Allina Hospital System lost a bunch of PCs, and they made it standard kit. So that was my story. Empower, share, gather, mobilize data. Do it securely. Understand your costs are being cut, and you dramatically have to change operating expenses. You have to build tools to help your clinicians coordinate care. You have to understand the cloud business model and make business decisions where then technology will follow. And as IT leaders, it's a business set of decisions about how you're going to consume IT, what's the compute model that you're going to use to deliver it efficiently to multiple clients, securely in multiple venues. A complicated story, but that's it. I thank you. Bunch of white papers, glad to chat. Thank you.